Hello, good morning. We're going to talk about diabetes. And I know that some of you guys print off the PowerPoints, and that's great. I'm going to go right along with the PowerPoints. If you did not print them off, that's fine too. You can take notes like you usually do in class, or you can pull up the PowerPoint off of Blackboard and follow along that way, whichever way works best for you. So, diabetes. What is diabetes? Diabetes means too much sugar in the blood. And by sugar, we mean blood glucose. That blood glucose is your main source of energy. And it comes from what? It comes from the food that we eat. The goal with a diabetic patient is to maintain tight glycemic control. Tight glycemic control, what does that mean? What that means is that we want a patient with diabetes to keep their blood sugars within certain parameters. We give them a very specific parameter to say we want your blood sugar to be no less than this, but no higher than this. So that's the parameters. And in order to gain tight glycemic control, we want those patients' blood sugar numbers to fall right within those parameters. What helps our blood sugar to stay within those parameters? And that would be insulin. Insulin is a hormone that the pancreas makes that helps that glucose from the food that we eat get into the cells to be used for energy. So diabetes patients, when we think about how often we should keep an eye on them, so to speak, so how often they should present to the clinic, present to their primary care, for an exam and a checkup, you want to be thinking at minimal once a year, so annually, at least annually. Now, when I practiced, I followed my diabetic patients closer than only once a year, just because there's so much that can happen with those blood sugars being out of control, and I don't want to go a full year before I find out, oh my gosh, Sally's blood sugars have been ranging in the 300s for months and months and months. And why is that? Why would we not want blood sugars to be in the 300s? Long-term complications. That's the problem. A lot of times diabetic patients with blood sugars that are elevated won't see consequences right away, but it's those long-term complications that we want to monitor for. So diabetes in the U.S., the two patient populations that I want you to think about as far as ethnicity would be the Native Americans and the African Americans. Some other risk factors for diabetes would be if the female has birthed large babies, like I'm talking like 9 pounds plus. Also, obese patients have an increased risk of developing diabetes, and those that are physically inactive also have a higher risk of developing diabetes. Okay, I am on the absence of insulin slide right now. So I want you, when we're thinking about diabetes, to think about the 3 P's of diabetes. Those 3 P's would be polyuria, which means what? Frequent urination. Polydipsia, which is an increased thirst and fluid intake. And polyphagia, and that is an increased appetite. So those 3 P's, oftentimes when we see those in patients, it's a guaranteed indicator that we probably better do a blood sugar check on them. So just some other definitions that I have here. The hemoconcentration, that's an increased blood concentration. So with this, you could think about a diabetes patient that's dehydrated. Hypovolemia, that means a decreased blood volume. And hypoxia means what? We've used this word. I shouldn't even have to define it. You should know it. But it's poor tissue oxygenation. on down in that list, the ketone bodies, this is an abnormal breakdown product that collect in the blood when insulin is not available. So it's an abnormal breakdown product that collects in the blood when insulin is not available, and that's a ketone body. So when these continue to accumulate, it can lead to metabolic acidosis. Kussmaul respirations. You guys, I know, have talked about that in assessment class, and we talked about it in fundamentals. But that's a deep labored respiration. And often, not always, but often, it is associated with metabolic acidosis. Now, I just wanted to talk for just a second about what the difference is in the Kussmaul respirations and the Cheyne-Stokes. So with the Kussmaul, you have a consistent, very deep breathing. With the Cheyne-Stokes, they are all over the place. These patients, they may breathe faster for a period of time, then the breathing may slow down, then they may breathe faster again. They even have some episodes of apnea. So just wanted to point that out to you. Hypokalemia can result from excessive urine loss of potassium. Just something I think you better write down just to refresh before the exam. Chronic complications of diabetes. I have listed there for you the retinopathy and so forth and what they all mean. So just make sure you're aware of that. Diabetes can cause blindness. Your diabetes patients, you should be recommending to them, or their PCP, their primary care provider, should be recommending to them that they have an eye exam yearly. That's important just to keep up with those changes that can occur with diabetes in the eye. All right. Macrovascular complications, cardiovascular disease. So under cardiovascular disease, we think about coronary artery disease, and that can be abbreviated CAD. So coronary artery disease happens when the arteries that supply the blood to the heart muscle become hardened and narrowed. So just be thinking of what's some things that could cause hardening or narrowing of these blood vessels. Cerebrovascular disease. This affects blood vessels and blood supply to the brain. So an example of this would be what? TIAs. We talked about those, the little mini strokes, the precursor that something bad's coming. The stroke or an aneurysm. Those can all be examples of that. Peripheral vascular disease. I don't have a bullet for that one, but I want you to go ahead and include that one. And that can be abbreviated PVD. This is a blood circulation disorder that causes the blood vessels to narrow, which decreases blood flow to the limbs. So we see patients complaining about neuropathy in their feet, and that would be an example of this. So this neuropathy, this peripheral neuropathy, it results when nerves are damaged. And we want to think, like I already told you, feet, but we also want to think about hands because they can also experience some symptoms in their hands. And by these symptoms, patients typically complain of pins and needles or a burning sensation. And a lot of times these symptoms are most commonly, especially if they're bothersome in the feet, these patients often complain at night. So it's like at night when they lay down and they're trying to fall asleep, then they notice that they've got this burning in their feet or these pins and needles in their feet. So some medications, excuse me, some medications that I want you to think about with the peripheral neuropathy would be Neurontin, or gabapentin is another name for that. It's an anti-epileptic. It affects the chemicals and the nerves in the body that are involved in the cause of a seizure and in some types of pain. So we may have a patient who doesn't have seizures, but gabapentin or Neurontin is on their pain or their medication list. So you want to be careful when you're speaking to patients about their medications and not say to them, and you're taking gabapentin, a seizure medicine, and they are thinking, holy cow, this nurse has given me the wrong thing because I don't have seizures. So you always want to make sure you know why the patient is taking the medicine that they're taking. Because like this one, it is given for seizures, but it's also given for that nerve pain. Another medication would be Cymbalta. And Cymbalta is an SNRI, and it is used to treat depression, but it's also used to treat nerve pain. So just remember, you can have a patient that does not have depression, but is on Cymbalta for nerve pain. If you start to talk to your patient about their medications, and maybe they're familiar with Cymbalta. Maybe it's a patient you're taking care of in the hospital, a patient that was admitted for crazy blood sugars, and they're having some neuropathy, and the hospitalist wants to try something to see if they can alleviate some of this pain for the patient. So they start them on some Cymbalta. So you, as the nursing student, go in and say, good morning, Miss Jones. Dr. T has decided he wants to go ahead and try some Cymbalta for you. You don't want to just leave it at that. Why? Because if the patient recognizes Cymbalta, they may get a little irate and say, hey, I don't have depression. I don't have anxiety. Why are they starting me on an antidepressant? So just be ready. Be ready to explain those things to the patients. Sometimes our doctors at Great Memorial are pretty good, but sometimes, depending on where you're at, the doctors maybe don't take the time with the patient to explain all of this to them. So that kind of falls on us when we're giving their meds, is to make sure that they understand their medication and understand why they're taking it. All right. Microvascular complications, eye and vision complications, and I have diabetic neuropathy listed here. We have the kidney issues listed there. Sexual dysfunction. A lot of times with diabetics, we find that the male diabetics have difficulty with establishing an erection. So that may be something that needs addressed. We do have medications that help with that. However, the provider really has to be careful because there are a lot of contraindications with those medications and so forth. So those patients would need to be followed closely as well. And cognitive dysfunction. So back to, I did forget one thing with the diabetic neuropathy. I did want to talk about that again just for a second. But the diabetic neuropathy, that causes a decreased sensation. So when the patients have this going on, they can be at an increased risk of falls because they may not feel exactly where their feet are at. And they're also at risk of an increased risk of infection. They may step on something and not even know it. I had, the gentleman wasn't my patient, but he was a patient of the provider that I collaborated with while I worked full-time as an MP, who had come in, and when we performed the foot check, he had a thumbtack stuck in his foot. It was one of the flat ones, so apparently he had just stepped down on it and hadn't noticed. We have no idea how long that had been there. But anytime we know from fundamentals, anytime there's a puncture to the skin or a break in our skin, even those of us without diabetes or any other pre-existing health condition, we're still at risk of infection. With these diabetic patients, they're at even more risk of infection. All right, so on to types of diabetes. I do want you to check out table 64 for the different types of type 1 and type 2 diabetes, and I do have page 1286. So as long as my page numbers match yours, we should be okay with that. But it's table 64 4. Okay, so type 1, sometimes we refer to that as juvenile diabetes. I don't like that particular name for it. Why? Because it's not always juvenile patients that develop this type 1 diabetes. So anyway, that is another name for it, but type 1. So some of these patients have an autoimmune component to why this happens. The pancreas can't make insulin because the immune system attacks it and destroys the cells that produce the insulin. So with type 1, I want you to be thinking beta cell destruction, and that's what leads to insulin dependence. These patients, they just eventually don't produce insulin at all. Type 2, or adult onset diabetes, this is the most common form of diabetes, and the body just doesn't use insulin properly, which is called insulin resistance. So when the body just does not use its insulin properly, we refer to that as insulin resistance. With action, prevention is possible. Specific causes of type 2 diabetes, they are unknown. With these patients, we want to teach diet and exercise. It's important, and I've had several patients that have come in with what we title them pre-diabetes, and with diet and exercise, they're able to bring those blood sugars down and keep them down. They're able to lose weight, which absolutely helps with their blood sugar regulation, and also weight loss helps with hypertension, which we sometimes see go right hand in hand with diabetes. So it overall just makes them healthier. Metabolic syndrome. This is also called Syndrome X. This is a cluster of conditions that increase the risk of heart disease, stroke, and diabetes. Features of this syndrome include abdominal obesity, hyperglycemia, which we know means what? Elevated blood sugars, hypertension, and hyperlipidemia. Now, let me just go back for a second, and I do want to tell you, in order for a patient to get the diagnosis of diabetes, there are a few ways we can do this. If they have 2 fasting blood sugar readings of 126 or more, they can have the diagnosis of diabetes. And we're going to talk about the A1C again here in a little bit, so don't freak out when I say it, but an A1C of 6.5 or higher is also diagnostic of diabetes. So if we have a diabetic patient, let's say the patient has type 1 diabetes and they're having surgery, it has been found that they have fewer complications, fewer infections, and they also have better wound healing if their blood sugar levels are a little elevated. So if they're in that 140 to 180 range, it has been proven that they have fewer complications, fewer infections, and better wound healing. So that's a big deal, and that's something that I want you to remember, because although we preach about blood sugar regulation, if we're working pre-op and the blood sugar is elevated a little bit, I want you to know, hey, that's an okay thing. Health promotion and maintenance, control of diabetes and its complications, that's the major focus for health promotion activities. Now let me just talk, I know my notes kind of go off on a tangent here, but about the insulin pump. An insulin pump is a medical device that's used for the administration of insulin. So there's this little tiny needle, this little tiny catheter that stays in the skin. if we have this little tiny needle that is staying in the skin for a duration of time, what are we thinking? By now, your mind should automatically think infection. We preach and preach that. So needles that stay in there, that stay in that skin for 3 days, we want to think infection. Okay? So with these patients that have an insulin pump, those needles need to be changed every 3 days. After that point, we are thinking, wow, we're looking at an increased risk of infection. Assessment, noticing. I want to just go into the blood testing here just quickly. A fasting plasma glucose. By fasting, we mean they have to not have had any intake of food or beverage for 8 hours. Now, can they have water? Yes, they can have some water. There are a few other things that are permitted for them to have, but right now, for purposes of learning, I want you to just remember they can have water, but they shouldn't have anything else to eat or drink. As I just said, with the blood glucose readings, 2 readings at or above 126, and an A1C of 6.5 or higher. Those are diagnostic tools used to formulate a diagnosis of diabetes. And always, I just told you 2 readings above the 126. I want you to always remember that we don't generally diagnose someone with something based on one blood report, based on one reading, okay? I have here, I want you to look at your Med-Surg table 64-7 on page 1289. So under blood tests, we also may do a 2-hour postprandial blood sugar. And this postprandial just means after the patient eats. So this range, if we're looking at a patient and we've done their blood sugars, we want to think, hey, these blood sugar results may be in the range of 100 to 140. I have another figure here that I want you to check out in your Med-Surg book. It is the blood sugar ranges, and that is on page 1281, and it's figure 64-1. Normal blood sugars, I was always taught all through my nursing, 60 to 110 is what was considered normal. Your book says 74 to 106. So as you can see, those results are close, and as we're learning, there are several normal parameters that are set different depending on the publisher, and there will also be some differences based on which lab you are using. So I want you to memorize the 74 to 106, but I also want you to understand that if the patient has a blood sugar of 110, we're not going to say, oh my gosh, they probably have diabetes, okay? So know your ranges, but also know that a little deviation in those ranges, that's not uncommon or unexpected, okay? Okay, ketoacidosis. Ketoacidosis is a serious complication of diabetes that occurs when your body produces high levels of blood acids called what? Called ketones. When does this happen? So this happens when the body cannot produce enough insulin. Clinically, with this patient, we would see a pH that drops, which would cause a stimulation in the respiratory control area of the brain, which then will try to buffer the effects of the increased acidosis. So what happens with the breathing? That rate and depth of respiration increases, and we get those respirations that we talked about early on in the lecture, those Kussmaul respirations. And that's in an attempt to do what? to excrete out that acid that's accumulating. And our body tries to do that by that exhalation. So those respirations become deeper and at a faster rate because they're trying to blow off that acid. DKA, that's diabetic ketoacidosis, can lead to dehydration. You may notice the deep, fast respirations. Tachycardia, which means what? I'm not going to tell you. You're going to have to look it up if you don't know. Tachycardia, orthostatic hypotension, and an increased urinary output. Symptoms of DKA. These patients may complain of excessive thirst, fatigue, malaise, dry mouth. You may notice this fruity, scented breath and mental confusion. If a patient comes in with confirmed DKA, you better be thinking IV insulin. And at our facility at Grant, 9 times out of 10, you're waiting on the chopper. So DKA, make sure you know those things about DKA. Interpreting. The priority collaborative problems for patients with diabetes include potential for injury or impaired wound healing, pain due to diabetic neuropathy, potential for kidney disease, potential for hypoglycemia, which means what? A low blood sugar that falls below that 70 range. Potential for DKA, which I told you means diabetic ketoacidosis. Teaching is so important because these diabetic patients are at high risk for wounds, especially on the feet. And this is secondary to that peripheral neuropathy, so that decreased sensation that they have. And it's also secondary to the poor arterial circulation, because we talked about the blood flow being lessened. Why? Because those vessels harden and narrow. So we would want to teach diabetic patients some things to prevent these risks. So one thing would be not to go barefoot. I love being barefoot. I'd rather go barefoot than wear my shoes. However, for these patients, this puts them at increased risk. So we want to teach them to not go barefoot. The toenails, we want to teach them to trim those straight across. If they get clipped when the toenails are clipped and that skin gets pierced, there we go again. They're at increased risk of infection. We want them to wash and inspect their feet daily. They should not soak their feet in the tub. They should also be aware that if they notice any blistering or any problems with the skin integrity, that they need to notify their PCP immediately. So these patients are at increased risk of burns as well because of the decreased sensation. So if they would be running a tub of water to get in to take a bath, we want to teach them, don't stick your foot down in to test the water. They should use a thermometer to check the temperature in the water. Planning and implementation, responding. Prevent injury from hyperglycemia. Hyperglycemia is a critical factor in the pathogenesis of long-term diabetic complications. So what does that mean? That means that for every day that these patients have this elevated blood sugar, they're putting themselves at greater risk for long-term complications. And these long-term complications, we're thinking about kidney damage, damage to their eyes, damage to their vessels. So long-term complications, you could be thinking about blindness. You could be thinking about kidney failure, which is going to cause them to have dialysis. You can also think about amputation of the lower extremities. Those are all things that can be tied as long-term complications with diabetes. We want to prevent injury, manage the pain, prevent infection, prevent injury, reduce the risk of kidney disease, prevent hypoglycemia, which is, well, I told you I wasn't going to tell you, so you have to look that one up if you don't know it. And we want to prevent the DKA. When a diabetic patient is sick, they need to continue their medication regimen. So sometimes if they get sick, they don't want to take their insulin, or they don't want to take their oral agents. It is crucial to preach and teach to these patients that even when they're sick, they have to continue to do this. They also have to continue to eat and drink. They should not exercise. That can change the blood sugar levels, and they should not exercise. We also want to teach them that when they're sick, because when they're sick, what happens to their blood sugar levels? They're all over the place. They should do blood sugar checks every 4 hours. Patient education, insulin storage. So it's important for these patients to know where to store their insulin and how long they can keep their insulin. Dose preparation, syringes, blood glucose monitoring. We want to teach these patients to avoid sharing any equipment for blood sugar checks to prevent infection. Small particles of blood can adhere to the monitoring device, putting other patients at risk. They should wash their hands before testing. And then I have exercise as an extra bullet on my slide. Moderate exercise, such as walking, helps regulate blood glucose levels on a daily basis. That also results in lowered insulin requirements for these patients with diabetes, which is pretty incredible because the patients, when they have to up their insulin, a lot of them see that as a failure. They screwed up and it's a failure that they have to. That's not always the case. Sometimes it's just the fact of that insulin production has just dropped again and they need that extra little boost. Insulin activates the sodium-potassium pump, increasing the movement of potassium from the extracellular to the intracellular fluid, resulting in hypokalemia. So insulin activates the sodium-potassium pump, increasing the movement of the potassium from the extracellular to the intracellular fluid, resulting in hypokalemia. If a patient needs a CT scan and they're currently taking metformin, we must hold the metformin. Why? So we hold it for at least 48 hours. Why would that be? Well, that's going to be because it affects their renal function. So if the patient has to have a CT scan, we're going to hold that metformin for 48 hours, and then we're going to check the renal function. And if all is okay with the renal function, then we may resume the metformin. What test would measure renal function? That's going to be the BUN and the creatinine. So the BUN stands for blood urea nitrogen. This test measures the amount of urea nitrogen in the blood. And the creatinine measures the creatinine. And the creatinine is a waste product that results from muscle breakdown. So I want you to look up what the normal BUN and normal creatinine level would be. and you need to have those. You need to have those wrote down, and you need to know those for the test. Okay. So why would we hold the metformin? Because it places the patient at a high risk for kidney failure. So the dye, that contrast dye that we use in the CT scan, puts a great strain on the kidneys. And the metformin does as well. So we're looking at a double whammy to the kidneys if we do not hold that metformin. Okay. Insulin. If we are teaching the patient about insulin, we want to teach them that they should rotate sites. And why is that? Because we can cause damage to the tissue if we do not rotate the site. The abdomen, that site has the fastest rate of absorption because of the blood vessels in that area. So we use that area frequently in the hospital setting. We also, a lot of times, will teach patients that that place is a good place for them to administer their insulin because it's a lot easier for them to get there than it is to get on their arm. Another place that we teach patients is a good place to self-administer insulin would be on the thigh. And why would that be? For the same reason I just said with the abdomen. It's an easy injection site for self-administration of insulin. It's important to remember and to teach patients that different injection sites have different absorption rates. So different injection sites have different absorption rates. It's just important to teach them that. Like we just talked about the abdominal site. It has a faster absorption rate. And why? Why did I just tell you? Because of the blood vessels in that area. A patient with diabetes, if they are not tolerating food, we have to prevent hypoglycemia in some way. So that way would be that we may need to administer dextrose 50% IV. So if they're not able to tolerate and keep down food, because of an illness that they're having, we may need to get an IV started on them to make sure we're keeping some glucose in there. Patient with hypoglycemia, some symptoms that you want to be aware of is confusion, shaky. You may notice that their hands are real shaky. They may have slurred speech, and they may be diaphoretic. Is it possible to reorient a patient while their blood sugar is low, while they're in that hypoglycemic state? No. You can attempt to all you want, but if their blood sugar is that low that they are experiencing this confusion and this slurred speech and they're diaphoretic, you're not going to be able to reorient them until that blood sugar comes back up. And that is just because they are so confused. It really cognitively messes with patients when their blood sugar levels are low. All right, guys, so that is a brief rundown of the diabetes chapter. I am happy to entertain any questions that you may have. I would prefer that you put those on Blackboard, and you can just, I'll open a tab up under the assignment tab, and you can ask your question there. That way everyone is able to see it, so I'm not answering the same question 20 times. And you may have feedback as well for that question, so I will have that up by hopefully close of the day today. Of course, you guys know today is Thursday and I have clinical at the hospital. So I will be there, and if I'm able to access it there, I will go ahead and get that taken care of for you. If not, it will be up when I get done at clinicals today and can get somewhere where I can put that up for us. So, as I said, any questions you have, I'm happy to entertain those. If you have comments or just something you want to add to the lecture, it's fine for you to put all of those posts there. So, anyway, I hope this is helpful to you, and I will see some of you at clinical today, and those of you that I do not see, I will see you Monday. Just a reminder, Tuesday, you need to be at campus, there at Eastern Campus, no later than 8:15. Okay, we have the diversity training that we have to do, and then my exam on diabetes and intracranial regulation will follow on Tuesday. We should be done with the training by 11:30 and be able to go ahead and start the exam immediately following. Okay? All right. Enjoy your day.